Welcome everyone, and thank you for joining us this evening for the MyIBD Learning webinar series. Today's webinar is Diet, Body, and Your IBD. It's complicated. And tonight we will be providing an overview of commonly tried evidence-based IBD diets, identifying signs of disordered eating and why there's no one-size-fits-all diet, understanding the psychosocial impact of diet on body image and self-confidence, and then also providing tips on how to approach nutrition and how to maintain a healthy body image. To introduce myself, my name's Macy Stahl. I was diagnosed with Crohn's disease when I was just 8 years old. Currently, I'm a senior at the University of Virginia studying kinesiology, and I serve as advocacy chair on the National Council of College Leaders here at the Crohn's and Colitis Foundation. I'm super excited to be facilitating tonight's program. The MyIBD Learning webinar series features different educational topics throughout the year, and we invite you to view the Foundation's upcoming MyIBD Learning webinars and in-person regional events at Crohn's Colitis Foundation/MyIBD Learning. Just want to give a few housekeeping reminders before we begin. This program will be recorded and accessible to view after completion of tonight's program. If you have any questions for our presenters, please enter them in the Q&A box, and we'll try to get to as many of them as possible. If you're interested in live closed captioning, there are two ways you can access it: by clicking on the CC button on the bottom bar and clicking on Show Subtitles. If you don't see that option, you might need to download the latest version of Zoom. I would like to thank our sponsors tonight, Nestle, Takeda, and Ferring Pharmaceuticals, for supporting the MyIBD Learning webinar series. Their support enables the Crohn's and Colitis Foundation to continue to provide important education for patients and caregivers. Now, I would like to introduce this evening's experts who we'll be hearing from tonight. Unfortunately, Jennifer Thompson wasn't able to join us tonight, but we're thrilled to have with us registered dietitian Brittany Rogers. Brittany is an IBD specialized virtual private practice registered dietitian nutritionist, certified personal trainer, and behavior change specialist who was diagnosed with ulcerative colitis herself about 20 years ago. We also have with us Kate Tomasino, who is a clinical health psychologist and serves as co-director of behavioral medicine for digestive health at Northwestern Medicine. Thank you both for being here tonight, and thanks to everyone who's joining us in the audience. And at this time, I'm going to pass it over to Brittany.
Okay, perfect. Yeah, hopefully you guys can hear me. So yeah, my name is Brittany. I'm excited to present tonight to you guys, and yeah, let's jump in. The only disclosure is that I have a private practice at Roman Well. And today I basically want to be talking about why diet is important in IBD, some potential drawbacks of diet restrictions, overview of some common IBD diets, and then just describe, talk a little bit about a relaxed diet approach. So yeah, let's get into why diet is important in IBD. So research suggests that diet may help to reduce inflammation, symptoms, and may help certain medications actually work more effectively, can help prevent and treat malnutrition. I think a lot of people with IBD have a lot of questions around their diet. And if they go unanswered, they may go to the internet, where there's a wide variety of conflicting nutrition information out there. And that can lead to a lot of feelings of overwhelm and confusion, trying multiple diets and restricting multiple foods or food groups, and even skipping meals to avoid symptoms because you're just so overwhelmed with not knowing what to eat. So some potential drawbacks of diet restrictions and interventions is something else I wanted to cover, because I think a lot of times people feel like diet manipulation is benign, and that's not always the case. So, I think I hear this statement frequently about how, avoiding foods due to fear of triggering symptoms is common. And I think that's accurate, but I also don't think it's healthy to normalize restriction either, because restricting too many foods and food groups could lead to nutrient deficiencies, an unhealthy relationship with food, and malnutrition, which has been associated with worse disease outcomes. If you feel like, your relationship with food is unhealthy, or you feel like you are restricting a lot of foods, then reach out to an IBD dietitian to help you find, a diet that's really going to be helpful for you. So you can ask your doctor for a referral. You can search. The Crohn's and Colitis Foundation has a provider directory, and you can search for nutrition professionals, and then you can also search for IBD dietitian online. So therapeutic diets and some potential contraindications that may be connected to those. So therapeutic diets are specific diets that are intended to improve inflammation or symptoms in people with IBD. So it's important to note that there's varying amounts of research to support their use. They're intended to be used only for a short period of time, sometimes 12 weeks, sometimes shorter, sometimes more. And then also, you should also only be doing these things under the recommendation of and under the supervision of your doctor and your dietitian. Therapeutic diets may not be right for you if you have experience feelings of guilt or shame after eating certain foods already, if you don't believe your relationship with food is in a good place, or if you have a history of or an active eating disorder, therapeutic diets may not be appropriate for you. But I think it's always important to talk to your IBD care team to really discuss the pros and the cons of diet therapy before trying a diet, especially on your own. So I want to get into a few diets, and I'm not covering all of them. There's tons of IBD diets out there, but I wanted to talk about some of the most common and the most researched diets. So the first one is exclusive enteral nutrition, and this is where all of your calories come from a liquid nutrition formula, and you basically drink it or you take it through a feeding tube, and this is typically for 6 to 12 weeks. It's actually the first line treatment for pediatric patients with mild to moderate Crohn's disease. And it's actually very effective. A lot of the times, the efficacy for exclusive enteral nutrition for the induction of remission is estimated to be between 50 and 75%. And exclusive enteral nutrition also, is helpful for preventing the kids from being on steroids, which can protect their bones for a little bit longer. Now, I will say, the drawback of this diet is that you basically don't get to eat food, and that's a huge part of our life. The next diet is the Crohn's disease exclusion diet with partial enteral nutrition, and it's a 3-phase diet. During the first 6 weeks, 50% of your calories come from a specific nutrition formula, and 50% come from certain mandatory foods such as chicken breast, potatoes, bananas, and certain allowed foods like spinach, melon, and strawberries. And there's also certain foods that are excluded from the diet, such as dairy products, animal fats, and processed foods. During the next 6 weeks, 25% of your calories come from the formula and 75% come from the diet. That includes more foods than in phase 1. And the last phase is the maintenance phase, in which allows for more free meals, but hasn't been researched as much. Current evidence suggests that this diet can induce and maintain remission in children with mild to moderate Crohn's disease. It's also been suggested to significantly reduce fecal calprotectin levels, which is a marker of inflammation, in adults with mild to moderate Crohn's disease. The diet has also interestingly been researched alone without partial enteral nutrition, and has been suggested to be just as effective as the Crohn's disease exclusion diet with partial enteral nutrition for the induction and maintenance of remission in adults with mild to moderate Crohn's disease. The diet has been recently researched in UC patients that have gone ileopouch anal anastomosis surgery to help reduce chronic pouchitis symptoms with some preliminary success. Now, compared to exclusive enteral nutrition, this diet may be easier to follow because you do get to eat some foods. But I would say one of the drawbacks of this diet is that there's definitely, there's a list of mandatory and allowed foods as well as excluded foods. And that can lead to increased morality associated with foods. The specific carbohydrate diet, or SCD, includes fruits, vegetables, fish, meat, homemade yogurt, aged cheeses, and excludes grains, processed foods, soy, and certain vegetables such as potatoes and corn. The SCD has been suggested to decrease symptoms in those with mild to moderate Crohn's disease. And a randomized controlled trial compared the SCD to the Mediterranean diet, and there were no significant differences between the diets in their impact on symptoms, fecal calprotectin levels, and C-reactive protein, which is another form of measuring inflammation in adults with mild to moderate Crohn's disease. A benefit of this diet is that it does promote consumption of more whole foods and promotes more, cooking at home. But I would say another drawback would be that it contains a list of legal and illegal foods, which can definitely also lead to an increased morality associated with foods. So the low FODMAP diet is a 3-phase diet, which includes an elimination phase in which certain foods are allowed, which certain foods are avoided, such as garlic, apples, and asparagus, a reintroduction phase in which you test your tolerance to specific high FODMAP foods, and an adapted phase in which you add all tolerated FODMAP food groups back into your diet. Now, this diet was originally developed for individuals with irritable bowel syndrome, or IBS, as a way to reduce symptoms, but has also been shown to reduce symptoms in certain individuals with inflammatory bowel disease with overlapping IBS. However, I think it's really important to note that this diet has not been shown to reduce inflammation. And oftentimes, your doctor or dietitian may recommend this diet when you're in remission and still experiencing symptoms. A benefit of this diet is that it could actually help you to identify your trigger foods if you are sensitive to certain FODMAPs, which could reduce your symptoms. However, it can be pretty challenging to follow this diet, especially if you frequently eat at restaurants. Also, this diet may feel particularly restrictive if you're already avoiding certain foods due to your IBD. So it's definitely important to work with an IBD-focused registered dietitian if you do want to follow this diet. And then also keep in mind, sometimes a lot of people do the elimination phase for a very long period of time, and that is not what this diet is designed for. The purpose of it is to identify your trigger foods. So you really want to test those FODMAPs, and then the goal would be to have as wide of a variety of foods back in your diet as possible. The Mediterranean diet includes frequent consumption of fruits, vegetables, whole grains, fish, legumes, nuts, seeds, and olive oil. Eggs, poultry, and dairy are consumed in moderation, while red meat and sweets are consumed infrequently on this diet. Since the Mediterranean diet was just as effective as the specific carbohydrate diet in reducing symptoms and improving overall quality of life, and given that it is less restrictive than the SCD, this may be the diet that you want to try first before you try something more restrictive. Keep in mind that while the Mediterranean diet has been the one that's been researched the most, all traditional cultural diets that are balanced and minimally processed may also achieve similar results. A benefit of this diet is that it's plant-based and includes all food groups. It's also been suggested to reduce the risk for heart disease, regulate blood sugar levels, reduce the risk for many different types of cancer, including colorectal cancer. However, I will say, because this diet contains a lot of fiber, it can be challenging to tolerate, especially if you're not used to consuming high fiber foods regularly. So what can be helpful is slowly increasing foods high in fiber and adapting the texture. Both of those things can be helpful in improving tolerance. So I'd love to talk a little bit also about a relaxed diet approach. Since we are on the topic of disordered eating, a relaxed diet approach is one that really keeps in mind variety in the diet and cultural foods and food preferences and your enjoyment or pleasure in eating, and also sustainability of the diet. Relaxed diets also allow all foods in moderation. They don't villainize certain foods. They promote variety, are flexible and sustainable. So I want to give you a few tips for trying to implement a more relaxed diet approach. So the first is really focusing on variety, not restriction. So think about, instead of just completely restricting those trigger or inflammatory foods, think about trying to swap them out for better tolerated alternatives or for anti-inflammatory alternatives. Also, current guidelines recommend increased consumption of fruits, vegetables, foods rich in omega-3 fatty acids, while limiting red and processed meats, coconut oil, palm oil, and dairy fats. Instead of focusing on just, let's say, restricting red meat, for instance, focus on adding in more variety of different types of protein throughout the week. That way you're going to naturally decrease it, because you'll also have chicken and ground turkey and tofu and salmon and tuna and cod and eggs. And then the next tip would be to give yourself some options for dealing with trigger and inflammatory foods. I think since I'm using these terms, I should probably explain what they are, because I think a lot of times people confuse what these terms are. So trigger foods are really any food that triggers symptoms. These can be inflammatory or anti-inflammatory, and they're different for everyone, which is why everyone with IBD needs an individualized diet. Now, inflammatory foods are the same for everyone with Crohn's disease and are the same for everyone with UC. And inflammatory foods are really, foods that research suggests, when you frequently consume over time, increases the risk for active disease. What's tricky is these may or may not trigger symptoms in the moment. But here are some tips for dealing with those trigger or inflammatory foods. So first is to make a healthier yet satisfying alternative. So this could be swapping out ground beef, for instance, in a recipe for lean ground turkey, and maybe adding in some more seasoning so it's just as satisfying. The next tip is to reduce the portion of the trigger or inflammatory food in the recipe. So let's use a common trigger food as an example. So let's say you have, you love chili powder, but it triggers symptoms. We'll try decreasing the portion in the recipe to see if you can tolerate a smaller amount. Chili, and then keep in mind, chili powder may increase your symptoms, but it's not inflammatory. So we don't have research that it's causing your body harm. And then the last tip is to have it as is, because sometimes the symptoms are worth it. Sometimes they're not, but sometimes they are. I will probably never have my dad's spicy chili again, but I will probably do an adapted version for myself. I think it's important to know that trigger foods aren't always inflammatory. So just because they trigger symptoms doesn't mean that they're causing your body harm. And even inflammatory foods are considered inflammatory when you consume them frequently over time. So having them in moderation is okay. And then the last tip is to use some non-diet therapies as well to reduce symptoms. This can be really helpful for a lot of people because, I think a lot of people focus in on diet, but there's so many different evidence-based therapies that can be helpful for reducing symptoms, such as pelvic floor physical therapy, exercise, mindfulness-based stress management activities like a body scan meditation, and even gut-directed hypnotherapy. So yeah, hopefully that was a helpful presentation, but I am going to be passing the baton on to Dr. Tomasino, who will be talking about body image and food-related quality of life.
Thank you, Brittany. That was such a helpful presentation. And I'm just going to get my slides up and going. Okay. So thank you again. We heard from the dietitian perspective, and Brittany shared so much useful information and actually talked a lot about the psychological aspects of restrictive diets and diet interventions as well. So you're going to hear some overlap here, but I'm coming from the psychologist side. I am a psychologist at Northwestern. I work with patients who have GI disorders, and I specialize in working with patients with inflammatory bowel disease. I have nothing to disclose. And today we're going to be talking about food-related quality of life in IBD, body image in IBD, I'm going to talk to you about the risk of disordered eating and eating disorders in IBD. And then what I consider to be the most important part, we're going to talk about how to reduce restrictive eating and improve food-related quality of life and well-being in living with IBD. So food-related quality of life can sound a little bit researchy, a little jargony, so I wanted to talk about what this really means. When we think about food and we think about food and how it impacts us emotionally, socially, and psychologically, that's when we're talking about food-related quality of life. We know that food does more than just nourish us. It provides to connect us with other people culturally and socially. Food can be a source of pleasure and a source of entertainment. And so when we talk about food-related quality of life, we're talking about all of those things that go along with eating. And we know that there are a lot of changes that can happen to diet and eating patterns due to IBD that can impact socialization, recreation, and emotional health, and thus impact food-related quality of life. And unfortunately, there is good data across the lifespan that both in children, adolescents, and adults with IBD, food-related quality of life is reduced. So why is it reduced? We can make some assumptions, but one of the primary reasons is that there are a lot of confusing mixed messages, as Brittany was sharing, about the role of diet in IBD, combined with conflicting dietary recommendations. Less than 20% of people with IBD receive dietary counseling after their initial diagnosis. So a lot of people don't really get information from reputable sources. And this can lead to confusion and also fear, right? So many people develop fear of certain foods triggering symptoms or triggering a flare. They might attempt to follow multiple diet recommendations at once. They might fail to be reintroducing foods after exclusionary diets, and that can lead to a very restricted diet and impact food-related quality of life. I also think it's important to note that food-related quality of life can actually improve after surgical resection. A lot of people might fear surgery initially, but for some people, once they have a surgical resection, they're having some decreased symptoms, allowing for more liberal diet for those patients. So I think that's important to note too. It's not always what we assume. So what are these mixed messages that we keep talking about? I wanted to go over what I'm hearing in my office when patients come in and they're avoiding a lot of foods. They're really worried about how diet is impacting and impacting their disease, and they're impacting their quality of life. So we might hear that diet causes IBD. We might hear that diet can cure IBD, that all people with IBD should follow the same diet recommendations, that certain foods may trigger IBD flares or symptoms, and that diet has nothing to do with IBD, right? We might hear all of these different things from friends, family, the internet, and that can be super confusing. We might also get these shoulds from people. You should just relax about your diet or be stricter about your diet. We might hear that from the same people. And maybe just stop talking about your diet. I don't want to hear about this anymore. All of these things are messages that patients bring to my office that we have to work to clarify because of the impact on emotional health and the impact on their food choices and food-related quality of life. And so we're going to try to do some of that today. And Brittany actually did a wonderful job of clearing most of these mixed messages up. So being here is a great first step to getting that clarification. So taken together, what happens? People get these mixed messages, and then they're also attempting to manage and cope with IBD symptoms with their diet. And this can really impact people's relationship with food, leading to fear and anxiety around eating, fear and avoidance of certain foods or entire food groups, restrictive behaviors. So this might look like excluding those foods or food groups, limiting portions, not eating outside of the home, not eating at certain times of day or before certain activities. It can also lead to increased risk of disordered eating or an eating disorder, body image dissatisfaction, and the potential for malnutrition. So a little clarity. Again, as I mentioned, Brittany clarified a lot of this, but I wanted to just go to those things I talked about before. So while there's some evidence that there are certain foods that are definitely linked with inflammation, there's no evidence that diet alone causes IBD. I have some patients who think, if only I had eaten XYZ way, I wouldn't have gotten IBD. There's no evidence that your dietary choices caused your IBD. And diet changes might help IBD, but they're not exclusively a cure. There's also no one diet for IBD. Changes in the GI tract due to disease type and surgery history matter. Dietary recommendations need to be personalized. Diet changes may also be targeting overlapping symptoms of disorders of gut-brain interaction like IBS, as Brittany mentioned, and these dietary recommendations are different. So if you're hearing recommendations for two different diets, this might be why. So clarifying that can be helpful. While it is common to avoid eating or restrict foods in response to symptoms, foods are just one factor driving the symptom experience. So we want to be sure that we're addressing those other factors, not just immediately going to diet. If you're avoiding all foods because all foods seem to be triggering your symptoms, maybe it's time to think about other things that could be leading to symptoms. And then finally, how you approach your diet. Let's get rid of those shoulds. How you approach your diet or child's diet, this is really no one else's business. So you want to think about how you want to maybe politely and respectfully tell people that this is something you're handling on your own. So what about body image? Body image is an overall sense of your own physical appearance and also the evaluation of the functioning of your body. That part sometimes people forget. Body image dissatisfaction is not only having a negative view of your body shape, but it's also a negative view of your body functioning, feeling uncomfortable or anxious in your body, or negatively viewing your body in comparison to others. It tends to be higher in adolescence than in other life periods, and tends to be higher in women, though still affects people of other genders. And children with chronic conditions are more likely to be dissatisfied with their body than their healthy peers. In IBD, changes in body size, shape, and functioning due to both the condition and treatments can create body image dissatisfaction. And the rates are high with a really wide range. So it depends on how we're measuring this, but 20 to 80% of people with IBD have reported body image dissatisfaction at some point throughout their condition. It's linked with more disease activity. So if you're flaring, you're more likely to be less satisfied with your body. That makes sense. Weight changes and steroid use can have a big impact on body image satisfaction. So you might lose weight during a flare and regain in remission. And regardless of what you're eating, there can be changes in body composition due to inflammation. That can be difficult for some people to manage. Steroid use can also temporarily lead to unwanted changes in how you're viewing your body and what your body is looking like. And finally, surgery can impact body image, and that can be temporary or permanent changes in your body. So all of these things that I've talked about so far can put you at risk of developing disordered eating or restrictive eating in IBD. When we think about disordered eating and restrictive eating or eating disorders, we often think of eating disorders related to how people think about their weight and shape. So clinical eating disorders like anorexia or bulimia and related attitudes and behaviors. But other eating disorders also impact patients with IBD and really at a greater rate. So we're going to talk about that specifically. So what increases risk of disordered eating in eating disorder patients? For the more commonly known eating disorders, female gender and diagnosis of IBD in childhood or adolescence can increase this. Higher rates of depression and anxiety and body image dissatisfaction, and simply the recommendation to follow a restrictive diet can all lead to increased risk of eating disorder or disordered eating in IBD. And you can see some of these types of eating attitudes that even if people don't meet criteria for an eating disorder, about 80% in a smaller study did endorse feeling terrified about being overweight or giving too much time and thought to food, feeling that food is controlling their life. I hear this a lot, being preoccupied with the thought of having food, feeling guilty after overeating or after eating certain foods. The eating disorder or disordered eating pattern that we see more frequently in patients with IBD, though, is something called avoidant restrictive food intake disorder. This is also known as ARFID for short. ARFID is typically falls into a couple of different categories. It's when people are avoiding food due to the sensory components of the food, interest in food, and very importantly, in people with GI symptoms, fears about food and the aversive consequences of eating. So this is the concern about increasing GI symptoms due to eating. We know that there are higher rates of ARFID in patients with IBD than the general population. And it is associated with negative medical or psychosocial consequences. It might lead to weight loss or nutritional deficiency, dependence on supplemental feeding, or psychosocial or psychosocial impairment. And so this is what we're thinking about. Now, rates of ARFID in IBD have been estimated to be so high that we want to be very careful that we're not over-diagnosing and over-pathologizing people with IBD who are avoiding foods because they're fearful of symptoms. There is that, I'm going to go back one slide, right? We want to really think, how is this impacting a person's quality of life? And how is it impacting their nutritional status before we would make any sort of diagnosis or jump to the conclusion that it is ARFID? But in a study that came out last year led by Dr. Tiffany Taft, who's over here at Northwestern, we found that 53% of 120 IBD patients, that's more than half, met criteria for ARFID. So what this is telling us is that we want to be really careful with how we're measuring it. This is a traditional eating disorder or ARFID measurement scale called the NIAS. And there is another scale being developed specifically for patients with IBD that's going to kind of try to parse out what is really an eating disorder, what is reasonable response that certain foods might be triggering symptoms. Because most people know that they have certain trigger foods, as Brittany was talking about earlier, and avoiding those foods does not mean that you have an eating disorder, but there's a line there, and we want to make sure that we're thinking about that. If you do think that you have avoidant restricted food eating disorder, or if your child or loved one does, there are treatments for it. I work with people to treat that if it's a milder case of ARFID. Eating disorder clinics are getting better and better at treating this, but you'd want to go to someone who also understands the intricacies of IBD, and they're not just really advocating forcing all the different foods that you might know are a trigger for you and a known trigger, because sometimes there can be a little bit of a conflict there. So you want to consider really where you're going for eating disorder treatment. A lot of it is developing a hierarchy of feared foods and kind of building those foods back in. Okay, so we talked a lot about food-related quality of life, body image, and then disordered eating and eating disorders. What can we do about it? And this is the part I think is the most important, because this is the part that you can take steps to improve food-related quality of life, decrease risk of eating disorder, and improve body image. So how do we optimize food-related quality of life when living with IBD? The first is educate yourself and consider the source of the education and the recommendations. Being here today is a great step with that, because you know you're hearing information from qualified people in a reputable organization like the Crohn's Colitis Foundation. You want to ask your doctor if there are specific diet recommendations they would make based on your personal history, but then ask follow-up questions. So clarify, what is this targeting? Is this inflammation we're managing? Is this to reduce the risk of obstruction if you have a stricture? Is this to address gut-brain symptoms or IBS overlap? Is this temporary, or is this a long-term set of guidelines? How much flexibility am I really allowed? Rather than just assuming this is it, right? And people don't often come out with these recommendations right away. And then what support is available? And this is key. Connect with a registered dietitian specializing in GI. They are wealths of knowledge. People ask me sometimes when they come in there, what should I eat? I say, that's out of my scope of practice. I know some of this, but I'm going to refer you to the expert, and that's that registered dietitian. You want to aim for flexibility in a varied diet within your specific guidelines to improve food-related quality of life, decrease risk of eating disorder. And then remember that diet is just one factor. So automatically assuming that your symptoms were triggered by diet is not going to be the best bet for food-related quality of life. We want to think about what else might be going on. And that is one thing I work regularly with my patients on. And then practice how you want to respond to people offering unsolicited advice about IBD or about your diet. People laugh at me when I say practice, but I mean it. Write down what you wish you'd said in the moment, and then maybe read it through and make it something you feel comfortable and feel like it was appropriate to say, and then actually say it out loud, right? If you can do it with a friend or a loved one, someone you trust, that's even better. Again, people laugh, but it is so effective in making sure that you can really say that in the moment when you're feeling frustrated. How can we reduce risk of problematic eating patterns when receiving dietary recommendations? First, consider diet counseling a collaborative meeting. You're going to need to advocate and volunteer information and ask questions, because the dietitian or other medical provider who's giving you advice doesn't know your personal history as well as you do. If you're receiving information or being advised to follow an exclusionary or restrictive diet, make sure this is clinically indicated and ask why. Make sure that it's appropriately supervised. Ask who's going to support you in this. And make sure that you're receiving a plan not only for exclusion, but also for reintroduction. That's key to prevent disordered eating. You want to disclose any eating disorder history and body image concerns. I know this is really hard to talk about, but they were going to adjust how they're providing you information if they know that history. Finally, if you become concerned about restriction or anxiety around eating, remember that you know you best. If you notice that body image dissatisfaction is impacting your diet choices, or you're feeling guilty or sad after you eat certain foods, make sure you reach out to your provider for help. And if you have not received it yet, a referral to a dietitian or a behavioral health provider like a GI psychologist or other provider with that background. And then improving body image in IBD. So first, I think one of the number one things that a lot of my patients find helpful is connecting with other people with IBD. Maybe that's through social media, used responsibly. Maybe that's through a support group, but finding other people who understand and have been through it and know this is how steroids impact a body, right? Not everyone understands that, and so that can be incredibly helpful. Make sure that you're limiting social media and social comparison if you're having a period of time where you're not that satisfied with your body. It is demonstrated to make things worse and make your mental health suffer. So use wisely. Remember, the body image tends to wax and wane based on symptoms, weight changes, and treatments and surgeries. So how you're feeling now is not how you are going to feel on a continuous basis. Light movement and walking can be very helpful to help both with fatigue and body image, but also make sure you're taking rest when you need it. Adjust your expectations and pace yourself with fatigue and flaring. If you're comparing how you feel when you're flaring to how you feel when you're at 100% in remission, that's probably not going to be the most effective way for you to consider how you're doing. So make sure that you're paying attention to your expectations. And then I'd encourage you to focus on what you're capable of over what your body is not capable of. Our brain focuses on the negative because it focuses on threat to protect us. So we have to effortfully help our brain remember the things that are not threatening. So help list things, actually literally list things about your body that you like and that your body is capable of, because you're already, probably without even being aware of it, listing the things you don't like about your body and what your body isn't capable of. Along the same lines, be kind to yourself. Think about the other things about you that are important: sense of humor, kindness, loyalty, and so forth. And remember that people without IBD also deal with body image concerns as body image changes. It's universal and you're not alone. If you think you might need additional psychological support, working with a GI psychologist or similar provider can help with many of these concerns. Even if a provider like myself would meet with you and we think we can't necessarily provide the treatment, we can help provide referrals to a specialist in eating disorders if it has gone to that point. And you can also locate a specialist at roamgipsych.org. This is an organization also promoted by the Crohn's Colitis Foundation, and they have a great provider directory. So key takeaways: there is not one proper diet for people with IBD to follow. Brittany mentioned this, such an important message I think you can take away from today. IBD does commonly impact body image and food-related quality of life. This is worse during flares. It's common to restrict eating or restrict specific foods during a flare, and it might be difficult to add them back in once things are stable. And for some people, this restriction can lead to an eating disorder like ARFID. So just look out for this. Try to advocate so that if you're receiving these recommendations, you're at decreased risk. Reach out to a provider for support and referrals when you need it. And remember that body image and food-related quality of life can be improved with IBD. So taking steps like we discussed today can help. Thank you.
Fantastic. Thank you both so much for those informative presentations. Now I'm excited to invite you both back on to join us for questions from the audience. So as a reminder from before, please feel free to submit your questions to the Q&A box and we'll try to get to as many of those as possible. Fantastic. So to go right into it, we talked a lot about trigger foods from both of you guys. So how do we identify those trigger foods? I know it looks different for everyone, but what are some steps to take to start identifying those?
So yeah, I think I actually like to take a step back and say, before we start looking at trigger foods, I like looking at, the anti-inflammatory versus inflammatory foods in the diet and try to increase more of the anti-inflammatory ones: fruits, vegetables, a lot of omega-3 rich foods like salmon, tuna, mackerel, chia seeds. And then because sometimes that's all people need and they don't actually have a lot of trigger foods, and we want to keep our diets as expansive as possible. So let's do that first. Let's do some stress management activities and some, any sort of making sure that you're getting a good night's sleep. All of those things can play a role in reducing symptoms and reducing the restrictions that you have on your diet. But when we start looking at trigger foods, there are some common trigger foods. They are different for every person. Not everyone's going to have these foods trigger your symptoms. But some common examples would be like fatty or greasy foods, high lactose containing foods like cow's milk or cream, ice cream, unfortunately, spicy foods like chili powder, cayenne pepper, raw nuts, red and processed meats, corn and popcorn, and other kind of like tough to digest things in the diet, like cruciferous vegetables. So things like Brussels sprouts, cauliflower, kale, and yeah, certain raw seeds, like anything, seeds that are with a tough shell, like sunflower seeds, but not as much chia seeds, which are actually really packed with soluble fiber. So much so that when you put water or fluid with it, it actually gelatinizes. So it's packed with soluble fiber, that. And I would say, so that's kind of my approach with helping my clients find their trigger foods.
Brittany, if I could just add to that and reiterate what you said in the beginning. Obviously, Brittany knows this inside and out as a dietitian. But just a reminder that trigger foods, all those foods that she mentioned, aren't harmful necessarily to the GI tract. So while identifying a trigger food is kind of the food that makes you experience abdominal pain or diarrhea or the symptom, which might seem obvious, but some people forget that.
Yeah, that's an important point, that it doesn't necessarily cause your body harm. And even if it's also an inflammatory food, it's not a single portion of that that's going to cause your body harm. It's frequent consumption over time that makes a big difference. So that's an important point. And I think there's a big focus on like finding finding your trigger foods. And I think like it doesn't need to be as big of a focus as I think people make it out to be. There are those common ones, and it's really focusing on, you don't need to restrict them if they don't trigger symptoms for you.
Yeah, I also find a lot of people find it's the amount of that food as opposed to just the food and it's a little bit of the food. It's not like an allergy, right? It's different.
Correct. Yep, very different.
Mm-hmm.
Yep.
Awesome. Thank you both so much. And we also had a question about, like you were saying at the beginning of your answer, Brittany, inflammatory foods. Do you mind just circling back and giving a couple more examples of those?
Yeah, so the International Organization for the Study of IBD developed guidelines for the diet in 2020. And basically what they recommend is consuming lots of fruits and vegetables and foods high in omega-3 fatty acids, and limiting things like red meat. So some examples of that would be beef, lamb, pork, processed meats, like lunch meat or sausages or bacon, and then dairy fats. So that includes butter, cheese, ghee, ice cream, and then like coconut oil and palm oil. And then also certain processed foods, I should say certain additives that have been suggested to be inflammatory in mice. We yet don't have enough research in humans to say that definitively, but basically in general, if it's difficult to pronounce, you can probably find an option that with processed foods that have a simple ingredient that you could buy in the grocery store, and that is probably a good thing to choose instead.
Awesome. Fabulous. So I know you talked a lot about the Mediterranean diet, Brittany. So someone was wondering if this diet was shown to reduce inflammation, and how do inflammatory markers on this diet compare to other diets that are also, shown to improve inflammation as well?
Yeah, so I think what's important to know is the best highest quality research study we have on the Mediterranean diet compares it to the specific carbohydrate diet. And neither one significantly decreased the inflammation, but there were some small changes in those markers. There are also some studies that separately have shown some decreases in fecal calprotectin, but that we don't have like high quality studies on those yet. And the Mediterranean diet hasn't been compared to exclusive enteral nutrition, but I have to imagine exclusive enteral nutrition would outperform something like the Mediterranean diet.
Awesome. Dr. Tomasino, this is for you. So someone was wondering about hearing how the social aspect of explaining how healthy foods can also act as trigger foods. So kind of just that, that relationship. How does that work?
Can you say the beginning of that question?
Yeah. So they're wondering how just the process of explaining how healthy foods can also be trigger foods. So how do you explain to someone who's not familiar with IBD, a healthy food may also be a trigger food for someone?
Yeah, I mean, I think that really, it varies depending on the situation with who you're talking to and all of that. But I think one way to go about it is just to say that healthy foods, there's really no, there's not one definition of healthy foods, and what might be healthy for one person is not necessarily healthy for others. I think in general, as Brittany was saying earlier, people look for unprocessed foods versus processed foods, but even those might be a trigger food for someone with IBD. So I think it's just taking the word healthy out and explaining that doesn't really necessarily apply here. There are other things going on with my body that might make a food work better or worse for me in a given situation. It's tough.
Yeah, very tough. Brittany, for you, do you have any advice or resources for dieting or on diets for patients who have a J pouch?
Yeah, actually, the Mediterranean diet has been suggested to be helpful. And actually, the Mediterranean diet is more of I would say more of a relaxed diet approach, which I like about it. But I even like looking at studies that are even, that don't have the title of diets on it. There was actually some studies that showed that just 2.5 servings of fruit a day decreased the incidences of pouchitis. So even just like trying to get above that threshold can make a big difference too. So things like that. But yeah, the Mediterranean diet has also been suggested to be helpful.
Awesome. This one's for both of you guys. So we have some patients and caregivers wondering where they can find GI registered dietitians and referrals to IBD psychologists.
Yeah, so the Crohn's and Colitis Foundation does have a provider registry, and there are nutrition professionals on there. And then also you can always put in IBD dietitian into Google, and people will come up. Yeah, and then also asking your doctor for a referral to one.
Mm-hmm. For psychologists, the last time I checked the Crohn's and Colitis website, they have a beautiful page on mental health and IBD and emotional health and IBD, but they did also direct people to the RomeGIPsych.org website. So it's Rome, like Rome, Italy, ROME, GI, like gastrointestinal, psych, PSYCH.org, RomeGIPsych.org. And I think this will be available to view after, and it is on one of my slides.
Awesome. Thanks both. For Brittany, one of our participants has read a lot about how some patients going on strict diets like the keto diet or gluten-free diet for only a couple of months and have reported, miraculous changes in their symptoms and quality of life. So what are your thoughts on staying on a long-term relaxed diet versus going on a short-term restrictive diet and trying to reduce inflammation and reset the gut microbiome?
So yeah, I think like my position is always on the side of having a more relaxed approach, because I think that it just puts so much weight on your shoulders when you have that restrictive diet. And, I also wonder how much of sometimes like worrying about something being inflammatory is like causes more symptoms than actually just eating that inflammatory food to begin with. And so, yeah, I'm a big fan of like doing everything we can, including diet, lifestyle, medications, therapy, everything that you can do to help yourself feel your best. But not having that huge weight on your shoulders where like, on that diet, I did have something different one day and now like, and that's a lot of pressure. I often tell patients like, do you know any other 19-year-old who's in college, who's meditating every day, who's prioritizing her sleep quality, who's focusing so much on her diet and doing all these things? And like, and this is case for like many people other than just that person, but, and it's like, no, I don't know anyone who's focusing this much on their health. And sometimes like you're doing it all and it's still not enough and it's upsetting. But I think like, I think having that more relaxed approach where you can actually still live your life, you can enjoy eating, you can go out to restaurants, makes it easier to stick to, these dietary, changes.
Yeah. Kate, do you have anything on that?
Yeah, just to add to what you're saying, right? We know that these are all different factors that can affect disease course to some degree, and it's to some degree, right? So there's a huge amount of this that is out of our control, and it's so easy to try to control as much as we can, and maybe a bunch of stuff we can't, right? That's what we're trying to do with these behavior changes. So at a certain point, just to build on what Brittany is saying, is the stress that's created by trying to change every single thing actually causing more of a problem than is it a solution? So just kind of considering that when you're living your life and thinking about how you're approaching the lifestyle management of IBD.
Yeah, absolutely. Great points there. Brittany, what would you say the best foods to eat are when flaring with symptoms like loose bowels, vomiting, and abdominal pain?
That can be very different for every person because it could also, it depends on if the person has like stricturing disease. There's many factors that could be playing a role, but and it depends on if they have UC or Crohn's. I'm assuming Crohn's, but it could be UC. So I would say it's tough. Actually, it's really hard because if I would base it off of what you're currently eating and work from there rather than saying, this is the right food, these are the right foods to eat. Yeah. Research has only, I think we have like 2 studies that have shown like, we give patients surveys and say, which foods alleviate your symptoms? And there's not a lot of foods that are overlapping there. But I will say there's one that yogurt and bananas are 2 that are listed. I think like if you're vomiting, definitely trying to make sure that you're properly hydrated and you're also getting in some nutrition. I know sometimes that could be like soups or it could be smoothies if you can tolerate that. And if you're used to consuming some fiber, that can actually be really helpful because it's providing fluids and nutrition. And I know it's really hard to eat when you're nauseous, but it's also really important to eat because sometimes actually not eating can make nausea even worse. And even oral nutrition supplements may be an easier thing to keep down. So those are kind of some ideas, but yeah, it's very much individualized, and I don't want to have someone like completely change their diet to what I'm saying when if I knew what they were eating, I would recommend something else.
Awesome. And then again, for you, someone's wondering if you have any opinions or recommendations for a low residue diet. They're saying that that's the most specific dietary advice that's been provided by their GI so far to help reduce inflammation.
Okay. Well, so to my knowledge, I don't know if there's any studies that suggest a low residue diet being helpful for reducing inflammation. That was, and I don't want to say anything about like the provider or anything like that. Typically, I will say that's a common kind of antiquated recommendation that a lot of like professionals were taught for years and years. We're taught everyone with GI conditions, put them on a low fiber diet or low residue. low residue diet has actually been minimally researched at all. So really it's low fiber that oftentimes people misuse those terms, but even a low fiber diet, we know for Crohn's disease patients, actually, patients who consume, the most fruits and vegetables were actually 40% less likely to flare within a 6-month time frame. So, things have changed since that research study. And I know a lot of times fruits and vegetables can trigger symptoms in the moment. So that's where adjusting the texture of the fiber, cooking it, blending it, pureeing it, and slowly increasing the amount can all help improve the tolerance. But yeah, I can't speak to, I wouldn't want to recommend like that specific diet in general, though.
Yeah. Fabulous. One more question for both of you all before we have to wrap up here. Can either of you present some suggestions on how to make recommendations to an adult about 20 years old who might not want to hear them about diet?
I think so much depends on the relationship, right? So is this a parent? Is this a friend? Is this a partner? Is this a cousin? Who is this person, and who is the person making the recommendations? But I think, so in some regard, are you in a place that you should be making recommendations to that patient? Might you recommend they come to see a program like this? But I think I would defer to Brittany for the specific recommendations, but I would just say really consider why you want to have that conversation. Is it because they're really, really, really restricting and you think that they could benefit from increasing flexibility in the diet? Then I think maybe there's a conversation to be had about, I'm concerned about how you're feeling lately. And I'm wondering if the way that you're approaching diet is making you feel bad a lot of the time, being open to talking about it, focusing on how it's impacting life as opposed to what you should and shouldn't do based on the webinar I just went to, right? Because I think that might be immediately rejected. We want to approach people in a way that is going to be received. And often it's, how are you approaching this? How is this impacting you? And then maybe there's going to be an opening to provide some suggestions, but I'd wait and make sure they're ready to receive them.
Yeah, I liked what you said. I agree with the fact that I think it can also be, coming from a professional versus a parent can make all the difference too in that. I have many college age males that I work with, and their parent, after speaking with them, they did want to make changes, but it was because their parents said that they should make changes that they didn't, and they didn't see also that how much one little change can actually make a difference in their symptoms. So I think it's it can be one of those things where it's like when you hear it from a family member, you kind of roll your eyes, but then a professional tells you and you believe them and you do it, so it could be, maybe that could be a factor too.
Mm-hmm.
Awesome. Well, thank you both for sharing your knowledge and answering all those questions from our audience. For more information, we encourage you to check out the Crohn's and Colitis Foundation's website at crohnscolitisfoundation.org, where there are specific resources for children's, teens, young adults, and parents. And you can also contact the IBD Help Center to talk with a specialist about IBD-related needs at 1-888-MY-GUT-PAIN. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate any feedback you have, and it'll help us plan any future programming. Before we say goodnight, we want to invite you to view the Foundation's upcoming MyIBD Learning webinars and regional events at Crohn's Colitis Foundation /MyIBD Learning. Thank you all so much for attending, and I hope you have a great rest of your evening.
Thank you.